And now we have Dr. Jicha.
All right, thank you.
Thank you.
Well, it sounds like Dr. Nelson covered an awful lot as we touch base. I'm going to pick up with some of these sorts of things and really talk about diagnosis and care. So let's see if I can get these to work. And I really wanted to start, by really talking about the extent of the problem. And this slide is an old slide, but we're actually not doing much better nowadays. The numbers are about the same. So the dark navy blue bars show how many people actually have dementia, mild, moderate, or severe. The next bar over in gray is how many people are diagnosed out of those that actually have the disease. Look at mild. Oh my God, that's horrible. That's horrific. Now we move over one more, right? And even in severe, look, we're not diagnosing everybody. Severe dementia. And then we look at the light blue, who's being treated. Well, very few people with mild disease they're not diagnosed and they're not treated. We do a little bit better with moderate, and then severe, all of a sudden we're not treating them, Well, that's just, that's not really a time where we should be throwing in the towel saying there's nothing that we can do. We should be helping folks. And then that's really any kind of treatment, but, really what's considered, gold standard care, medicines like Aricept and Episil, really very few receiving medications. So that's horrible. So one has to think about why is that the case? And this is, the real crux, there are several reasons why we're not diagnosing and treating. The first is that the patient themselves is not aware of the symptoms. And that's a blessing. I always say every cloud has a silver lining. To me, it's a blessing that Alzheimer's patients are oblivious to the fact that they have a problem. The rest of the family thinks I'm crazy. Is what we get. The patient's never in denial. People who forget that they forget. And then folks start to get worried about, oh my God, the evaluation. This is, we're going to be at doctors left and right. They hate that. I can't even get them out of the house, to go, visit with the family. How am I going to get them into the doctor? How am I going to do all these things? And what's it going to cost me? There are concerns about this. There is still a general belief, and we've been fighting this for decades, as you all know, that memory loss and cognitive decline is just a part of normal aging. It's not. It's always a sign of the problem. The same as we wouldn't say if somebody can no longer walk. Well, that's just because you're old. We'd bring them in and we'd say, why aren't they walking? Let's figure out what's going on. So it's not part of normal aging. And there is a widespread belief still, and we've been fighting against this, by doctors as well as the general public. But there's nothing we can do anyway. So why would we bother? And that's really, that's why this is so horrific. To me, this is horrible. Anyway, so people need to understand the diagnosis. Now, I will argue a little bit with Dr. Nelson, who says everybody should come and see me because it's hard to get in from the specialist. And we already know that primary care doctors are the front lines, and a lot of the causes for memory loss are non-degenerative. As a matter of fact, we studied this here in our community-based cohort of people who are normal over the age of 65, those that went on to develop a memory problem, and we looked very carefully at, all right, they're not aware of a memory problem. We're starting to see it on their routine testing. What's the cause? And we find that at least 1 out of every 3 people who look like they're coming down with Alzheimer's actually have a medical problem, a vitamin deficiency, a thyroid problem, something that the primary care doc. Now, when we look in my clinic, we don't find that many people. The most of them do have a disease like Alzheimer's. Why? Because their primary care doc already fixed the other third. So always good. And then we need to demystify that process as well. And people need to know that we'll work with them. So certainly when folks come in standard and with any doctor, we get a lot more time to spend with patients, which I really like, which is wonderful. But we ask questions. Tell me about your memory and thinking. We do a physical and neurologic exam. Now, sometimes people are really petrified of the test of memory and thinking abilities. And this is just, what we call the MOCA. It's one of the many tests that we can get. It's got cute little animals on it. Nonetheless, petrifies folks. So I had a young lady in the other day who has a lot of an inability to see her own problem and a lot of anxiety. And we could say I started memory testing with her, and it was not going to go anywhere. So we shift gears. I used to have a young lady that used to come in. She refused to even go near the exam rooms. So her husband would come in, and her husband would go sit with one of the staff member, one of our family care specialists, and I'd sit out in the waiting room with her, and we'd leaf through magazines together. And I'd be like, "What do you think about this picture here?" And testing her visual-spatial function. I don't have my glasses with me. Could you read this, for me? This looks important. I never knew she was being evaluated. And for years, for 10 years, I tested her in the waiting room. Well, let's stand up. Let's go to walk. Do you need to use the restroom? Let's go get something to drink. So I could see her walk and examine her neurologic movements, oblivious, And that's wonderful that we can do that. So it doesn't have to be scary as well. We always do order some blood work, and it's a requirement to take a picture of the brain. So a third of folks, that we look at who are developing memory problems may have a vitamin deficiency or a thyroid problem, but another 20% may have a stroke that nobody's ever picked up on before. The areas, we have these algorithms to recognize a stroke, fast algorithms, do you see weakness, a loss of sensory, loss of vision, trouble with language? Then you have a stroke, going to see the doctor. That covers about 10% of your brain. The other 90% is about thinking, behavior, and other activities that people don't clue in on when we see that, or it could be a buildup of spinal fluid. In rare cases, I have folks that come in to see me for, evaluation of Alzheimer's disease, and I find a brain tumor. God forbid, sometimes benign, sometimes not, but that is different. And so exactly as Dr. Nelson said, we're trying to rule out other medical causes, things that we can fix, because I love to fix somebody and say, you don't have Alzheimer's disease, you're great, you can go home. There are other tests that can be used, and these are becoming more important with the new medicines that are out there. PET scans are imaging studies that can actually look at the same thing that Dr. Nelson looks at under the microscope, but we don't have to wait for somebody to die or do a brain biopsy. Right, and that's good, because I always tell people we never take a piece while you're still using it. Right, we can see exactly what Dr. Nelson would see under his microscope with these PET scans. Sometimes spinal fluid tests, and I know everybody always cringes, says, "Oh my God, spinal fluid." The truth of the matter is, it takes about 10 minutes. I do them here in the clinic all the time. I ask people, lift your shirt up, clean their back off just like a blood draw from your lower back, pop a needle in there, get their spinal fluid, directly measure what's going on in the brain. Sometimes other tests, brainwave tests or the like, very, very important. And you can see, my little diagram on the bottom, healthy control brain. It's big and plump and it fills everything out. But this Alzheimer's disease brain is starting to shrink. And especially these areas, this is the memory area, we can look right at that and say, uh-oh. Normal aging, our brains will shrink. We're losing nerve cells, but it shrinks like a balloon that you're letting air out of, right? You never let air out of your balloon and part of it shrinks and the other part stays fluffy. It all shrinks together. In these diseases, certain areas shrink quicker than others. And this is a real clue for us that not only is there no brain tumor or no stroke here, but we're losing cells in a pattern that represents Alzheimer's. Now, what do we really need in the world? Well, how do we diagnose diabetes, right? You do a blood test and see what somebody's sugar is. And how do we diagnose high cholesterol? Well, you do a blood test and we tell you, that your cholesterol's too high. And so our paradigm for medicine is, where's the blood test? And we've had trouble with that because things that are in the brain don't make it out to the blood. We have something called the blood-brain barrier, and things that are in the blood, fortunately, don't always make it into the brain, right? Like Dr. Nelson's daughter with COVID right now, thank God it's hopefully just hanging out in her body and not invading her brain. That would be good. But we've been able to develop the technology over the past few years. The things that we measure in spinal fluid, we're getting better and better at measuring in blood. So these are coming fast and strong. There are a few commercial tests that have already been given FDA conditional approval and that are out there. And everybody should realize your doctor actually can order these. Your insurance is not likely to pay for them, but they can be ordered. And Quest Diagnostics has a Alzheimer blood test that you can sign up for online, and somebody will come out to your house and draw your blood, and the accuracy is pretty reasonable. It's not perfect. It's not as good as coming in to see a doctor or professional. Those tests really are only for people with memory problems. Again, insurance doesn't pay for it, but many people are choosing to do this, a couple $100, but then they're stuck with, what if it says yes? What are they going to do? Sometimes 1 out of 10 people that are told on the basis of the blood test, no, you don't have Alzheimer's, actually do have Alzheimer's. It's an error in the blood test. So we need to be cautious about these, but I'm really excited because this is what our primary care practitioners are looking for. So this is the PET scan that I showed you. Here's a negative PET scan, no amyloid in the brain. And this is one that has Alzheimer's disease, just lights up here. We can tell that brain is full of amyloid plaques, just like Dr. Nelson would look at under his microscope. But we don't need you to be dead or to take a piece of your brain tissue. We can do this while you're living. And then we can look at the plasma test and you can see, that if you have a high blood test, you're more likely to have a positive PET scan as well. And so again, these tests are out there. This is what's called the preclivity test. It is commercially available. We're using this a lot in research. It's getting closer to routine use in the field. This is what we call a receiver operating curve, and the more of the square that you encompass, so this gold line shows us how accurate the test can be, and this is pretty darn good. It's about 90% plus, right about here, 90% accurate. So that's very helpful. It uses not only the blood test, but somebody's age. Age is the #1 risk factor for Alzheimer's disease, and genetics. And we also worry about protecting genetic risk. And the reason why we don't use these blood tests on people who are normal is because if you have a positive Alzheimer's blood test or a positive genetic test for Alzheimer's, then the insurance agents, loan lenders for the mortgage on your house, anybody that gets access to your medical records is going to classify you as Alzheimer's, even if you don't have Alzheimer's disease. We're all actually making these proteins all the time. We make them at very low levels and we get rid of them very, very efficiently. That goes awry as we get older. So important to use these with somebody who's trained in their interpretation, and then can help you figure out what to do, because diagnosis is really just a first step. So when people come into clinic to see me, I don't say, well, yep, all the testing's done, you have Alzheimer's disease, nice seeing you. And then I walk out of the room, that's not how it works, it's like, now we have a problem, and if it's not Alzheimer's disease, is it vascular disease, hardening of the arteries? What is it? And each answer gives us a different set of actions to push back, to fight back, and treat the disease. So I'm going to move into treatment, because that's at the end of the day, which I think is most important. So we do have medicines like Aricept, Nepozil, rivastigmine, Exelon, it comes in a patch form, and memantine, Menda. And these have really been a mainstay. The cholinesterase inhibitors approved in 1998, 1997, maybe, and memantine in 2004. And these are symptomatic medicines. So if this black line is somebody declining in their memory and thinking over time, if we give them a symptomatic treatment, we might see a little bit of benefit. And we might be able to hold them up and hold those symptoms back. But at the end of the day, it's not stopping the disease. They all wind up at the same place. What we've been looking for over time is disease modifying treatments. Let's change the disease. And now we've altered that black line. And we're going to give people extra years of life. We're going to slow the decline. That's wonderful. So how we treat people is they come in and we ask them about their symptoms. And I always ask the patients, no matter how impaired they are, if there was one thing today that I could help you with, what would that be? And that's important. And then I ask the family, if there was one thing that they need help with, what is it? And then we could work on the memory. We could work on behaviors. We could work on depression or hallucinations. We could work on walking problems that sometimes associate with memory problems. And then we bring them back every 3 to 6 months and ask the same question. What else can we do to get you doing better? So that's the overall strategy. Now, many people think, we've been hearing about these new medicines that, we're not going to use our standard medicines anymore, and that's not true. And so I want everybody to know there will always be a place for those medicines. So this is a study, right? You see Dr. Pete Nelson on it. Dr. Nelson and I did years ago. And this is looking, MMSE is memory test scores from 30 is great, 0 is not so good, and over years. And we looked at how folks change over time. And that's these four lines here. And what we can see is this is for people, it's based on genetics, but the important part are really these red lines. If we look, so not only are we helping people with their symptoms, but it's slowing the disease. Now, at the end of the day, they're all going to pass away at the same time. They're not going to change the disease. About 12 years on average, but a huge range. Some of our folks live for 26 years and do great. Some of our folks actually can develop memory problems and die of their Alzheimer's within 1 year. So it's a huge range. But we look at this and we say, well, an MMSE of 15, what does that mean? That is probably about the time when somebody's got to be around to help with daily activities. Now, before that, somebody may need help with their finances or may not be able to drive, but 15 is they can't make themselves a lunch or get something out of they'll starve if nobody's there. They're very important. These symptomatic medicines will delay that by a year, giving people an extra year where they can be home alone, make themselves a ham and cheese sandwich for lunch and turn on the TV. And an MMSE of 10, this is about the time when somebody really needs somebody around 24/7, or they're going to need to be placed in a memory care or skilled facility. 2-year delay. In that. That's pretty darn good. If you guys know what a skilled facility costs, does anybody know what a skilled facility costs? Unbelievable. 2 years of not having to pay that, I'm good for that. I think that's great. So there's a lot of people, so the folks out there, it's not just helping with symptoms, a lot of the doctors and people out there who say there's nothing you can do. Well, we can help people to do better. And we can delay these points of disability, and that's great. And, I don't know how much Dr. Nelson, I know there were questions about cancer, but, we think about cancer. There are some cancers that are incurable. But if you go to the doctor and they say you have an incurable cancer, we can use chemotherapy and radiation, and that will buy you a couple extra years of life to be with your family and the like. Almost everybody in the world would raise their hand and say, yep, I'd like a couple extra years, that's good. If I gotta go, I really want to see my daughter's pregnant and I want to see my new grandchild, my grandchild's going to graduate, the first person in the family to graduate from college in another year and a half, and I need to be around for that, valuable time. Well, the same holds true for our Alzheimer patients. So the doctors and the other folks in the community that say there's nothing that we can do, that's wrong, and we need to fix that thinking. So, but the real fundamental discoveries this year really has been a long path. It's been 25 years. 25 years. So in 1998, we had our first Alzheimer vaccine. Does everybody know that? Yep, we were giving people a vaccine for Alzheimer's still experimentally in 1998. It turned out that the vaccine was too powerful. It had significant side effects. And so about 6% of people that were vaccinated with that vaccine developed a fatal encephalitis of the brain. Now, the other 94%, if they mounted an antibody response, it removed the amyloid from their brain and showed a slowing of their cognitive decline by about 25%, which was pretty darn good. But nonetheless, we can't kill 6 people out of every 100 treated. Now, most of my Alzheimer patients, if I said, I have a vaccine for you, 94% chance it's going to help you, 6% you're going to die. Most of them actually would roll up their sleeves and say, I like those odds. But nonetheless, we can't do it. So in 2005, we went back to what we call passive immunization. Once you give somebody a vaccine, their body will take the ball and run with it. And so that encephalitis that people developed, we couldn't stop. We couldn't do anything about it. It was their own body attacking their brain. With antibodies that we give through an IV, we have complete control. We can increase it if people need more. If they start running into symptoms, we can decrease it. Sometimes we stop it for a month or two and restart it. We have complete control. And so 2005, we really turned to that. And I've been working on these antibodies since 2005. So a culmination of 18 years. So bapineuzumab was one of the first, and it showed us that we could remove amyloid plaques from the brain. The studies were a failure, partly because we didn't use PET scans or spinal fluid to make sure that they had amyloid in the first place. And it turns out that only about 2 out of every 3 people enrolled in the study actually even had Alzheimer's disease. So we learned some lessons over time and made the antibodies stronger and stronger. So second generation agents came out in 2012. Lots of different antibodies. In 2011, looking at these antibodies that I knew were coming out, we kind of put our nickel down on which ones do we think are going to work. And at that time, I really favored lecanemab, that we now know as Leqembi, and it is the first full FDA approval. I was right once. My wife will tell you once you were right. Once, the rest of the time you're wrong. Anyway, so those studies began. We carried lecanemab and some of the others through phase 2 studies. They looked promised, the ones that had promising results looked good. 2019, we were part of the phase 3 studies. We've learned many different things. We've learned that you have to have the right antibody, and it's best when used early. We learned that the risks and benefits can be very different with the different antibodies. And then ultimately in 2021, the first accelerated FDA approval showed that if you can effectively remove the amyloid plaques, you can slow the disease, but only by about 30%. So failures and successes this year, full FDA approval for the first of these agents. So why amyloid? Well, I don't know how much of this Dr. Nelson went into. We all have amyloid in our brain. Amyloid precursor protein, this little piece of squiggly blue spaghetti, gets cut by 2 enzymes and releases this green fragment. It starts building up and it becomes toxic. We know that true genetic Alzheimer's disease, all true genetic forms of Alzheimer's disease, have genetic mutations that work to increase amyloid production, this little green fragment. And interestingly, there's a genetic mutation that's found in a family in Iceland that prevents this green fragment from being produced. And you know what happens to those people in that family? They live to be 110 and they're sharp as can be at 110. They cannot get Alzheimer's disease. They are resistant to Alzheimer's. I wish I had some Icelandic heritage, but I don't, unfortunately. Anyway, pretty darn amazing. So that amyloid accumulation is the first step towards developing Alzheimer's. So these are the phase 3 results. We learned again about a 30% slowing. Won't stop it. And so we'll talk a little bit about that. We do know that there's still a risk of potential this white is swelling in the brain. Now, when we see this on an MRI scan, we can hold the medicine and let the brain recover, just like after you twist your ankle, it might swell up for a few days. You can't wear your shoe, but after a few days, that swelling goes down, your ankle starts feeling better and you can walk again. Same sort of thing. If you don't catch this, these medicines can be dangerous. So they need to be used by experts that can keep people safe. We also know what you see here in black is actually microscopic hemorrhages. I know it looks big, but it's actually microscopic. You wouldn't be able to see it with the naked eye. The MRI can see it because blood has iron in it, in our hemoglobin, and the magnet senses that metal and lights it up. So we do have to worry. We call this ARIA, amyloid-related imaging abnormalities. It's part of the process as we remove the amyloid from the brain. It first comes out of the plaques and flows to the blood vessels. And there, if you're removing it too rapidly, it will clog up the blood vessels or injure them, leading to swelling or bleeding. So if we see this, we know we're removing your amyloid too fast. We need to slow down, let your brain recover, and then maybe go back at it in a gentler way in different people. We can see that this happens spontaneously. About 2% of people with Alzheimer's disease will spontaneously develop this kind of swelling in the brain. And about 9% of people with Alzheimer's disease will, not on these medicines, will develop this kind of bleeding in the brain. Quite common. Those risks, though, do go up with these medicines. This is a scan. This is amyloid PET scanning. It shows a gradual increase for the people on placebo, but the people treated with the medicine by a year and a half completely removes the amyloid plaques from their brain. They become negative. And on all the other measures, other memory measures, COG14, ADCOMS, but really impressive is the ADL score, activities of daily living, 40% slowing of the loss of activities of daily living. That is powerful. So we learned some lessons from this. We learned by looking at different doses in phase 2 that we need this purple dose to get our effect. We've learned that the clinical benefit is in the 30 to 40% range, and this is consistent. And this led to full approval. We do know that ARIA still exists. We need to do this safely, but we can manage this. Very few people have symptoms from ARIA. 99% of the people that take these medicines are, even if they have a little bit of swelling or some microscopic bleeding in the brain, are not even aware that it's happening. It's very rare for it to cause trouble for anybody, but in some instances, it could be deadly. And that's why safety, number one. So people have talked about, is this meaningful? And again, when we look at 27 to 40%, 30 to 40%, we're talking about this up and down bar. But you see, as these curves begin to separate from one another, you get a little bit of benefit if you only use it for a year. You get a bigger benefit if you use it at 18, even bigger 24, even bigger 30, even bigger 36. So when we plot this out in an Alzheimer patient with a 12-year course, we potentially could buy people 4.5 years. Now let's add a symptomatic medicine to that and give them an extra year or two. Now we're talking about real impact. So the unfortunate part is that this new medicine, even though approved, is not for everybody. If the Alzheimer's is too advanced, we're going to see very little benefit. So it's only for those with mild cognitive impairment and mild dementia. Now, I'll remind you of the first slide that I showed you today, how few of those people are actually diagnosed. We need to get people in to be able to treat them if they want those additional 4 years, 6 years or more. Very, very important. We have to look for these side effects, and the only way to do it is with an MRI. So we do have folks that have a spinal stimulator or a pacemaker. Now, I'm working with patients right now. And one gentleman who came in and he has a piece of shrapnel in his orbit of his eye, outside of his eye, but a piece of shrapnel from his service in Korea. And at the time they said, it's better just to leave that in there rather than monkey around with your eyeball. So he's lived with that in there all of his life. He really wants this medicine. He came in to see me and I said, well, you have this metal in your eyeball. And he said, well, what are we gonna do about that? You know, I don't care if I can't have an MRI. And I said, well, for your safety, I need you to have an MRI. Let me send you to plastic surgery and ask them if they can remove this. So 2 weeks ago, they took him into plastic surgery. They made a little cut about the size, about the length of a piece of rice in the office with a local lidocaine injection, and took a little magnet and pulled out his little piece of shrapnel from his eyeball. No sutures, the incision is so tiny, and now he can have this medicine. Is that unbelievable?
Yeah.
So we have to work with our patients to figure out. I've had a few patients, you know, that have old metal pacemakers, and I said, you know, I'm like, you know, what's the shelf life of your pacemaker? And they're like, well, they're going to need to replace it in a year or two. I said, you know, you go in now and replace it. The new ones, you can have an MRI, and you can get your Alzheimer medicine too. Boom, off to the cardiologist, you know, let's change this, let's make sure we can do it. Some folks we will look at, I told you, this bleeding in the brain is spontaneous in 1 out of 10 Alzheimer patients. So 1 out of 10 Alzheimer patients, we may do an MRI and say, you're already bleeding all over the place. We can't give you the medicine because we could really run into trouble. So we need to understand that. People who are on blood thinners, as a matter of fact, there have only been 3 deaths with this medicine. All 3 people have been on blood thinners. 2 of them on Coumadin. 1 of them had a small stroke and went in and got the clot busting medicine. You know, if you get into the now 6 to 7% of people who get the clot busting medicine will bleed and die as well. So we don't know if it was caused by the medicine, but we have to be very, very cautious with people on blood thinners. Now, I do have many patients who have said, I could care less. If I have a big bleed, I would rather that. I would rather have a few extra years. That's a personal decision, in my opinion, on the basis. Sometimes we have somebody who's on a blood thinner for atrial fibrillation, and we can send them to the cardiologist for what's called a watchman. And a watchman fixes their heart so that they won't form blood clots anymore, and they can stop their coumadin. And then they can be on the medicine much safer. And then for people with ApoE risk genes, the risk of ARIA, swelling or bleeding is higher. So we need to talk with folks. And so we are screening people genetically so that we can tell them what their personal risk is. And then so that they can best make the decision. Yes, I want the medicine, or no, that risk is too high for me. Very important. And then we have to think about cost. And this is where we're doing a lot of battle on the national stage right now. Standard Medicare typically will pay 80%, but this medicine is expensive, and the MRI scans and the infusions. So we can look at folks, paying $5,000 to $10,000 a year, and our elderly on fixed incomes may not have $5,000 to $10,000 a year to spend. On the other hand, if it buys them an extra 4 years of life, is that worth $5,000 or $10,000? And if somebody told me, it's going to cost you $10,000 to live another year, I'd be like, here's your 10, and here's a 20% tip. For that. But we have to help our elderly that do not have the financial means. And so a lot of work is going into this right now. The company that makes the drug has a patient assistance program that appears, at least from talking to my colleagues across the nation, appears to be helping cover the copay, irrespective of financial needs, so that people aren't having undue burden. We'll see. In the meanwhile, we're pushing Medicare to just say, pay 100% of this. Some insurance companies are saying, we don't want to pay for it. You know who that's hurting? The people that don't yet have Medicare. Our young onset cases. Come in at 55, you don't have Medicare, you're not eligible for Medicare. Maybe we can get you Medicaid after a 2-year waiting period. Is it 2 years? Sarah, what's the waiting period?
It's on circumstances.
Depends on the circumstances, all right. Maybe Sarah can pull some magic tricks and get people in earlier. But really, really important. So we're trying to advocate with the Alzheimer's Association at the national level. Come on, everybody. It used to be that Medicare was the lowest common denominator. If you were selling insurance and your insurance didn't provide at least what Medicare did, you wouldn't have any clients. You'd be like, oh my God, your coverage is worse than Medicare. Nowadays, Medicare has risen to doing more than it's forcing, through embarrassment. I'm okay. I'm okay with embarrassment anyway. So this is a recent study that was done at the Mayo Clinic, and they actually looked at their folks and looked at how many people may be eligible for this medicine that have Alzheimer's, and they came up with about 17%. They're saying that they probably were underestimating, but they still think it's about 20 to 25%. So 75% of the patients are not going to be eligible, but we have 6 million with Alzheimer's disease. Oh my God, maybe we can help 1 million, maybe 1.5 million. That would be wonderful. Then we think about people with mild cognitive impairment. There's another 6 to 8 million of those, and we might be able to help more of them as well. We may actually be able to help millions, 3, 4, 5 million people. That would be wonderful. So I think it's worthwhile. Few things we don't know. We don't know how long to treat. We know it takes 1.5 years to get all the amyloid out of your brain. Can we stop at that time? Unless it comes back again. We do know it comes back again. We know the rate at which it comes back is such that you will rebuild your Alzheimer amyloid in about 5 to 7 years. So maybe we just have to treat people every 5 years. Maybe we have to continue to treat them so it doesn't build back up at all. We don't know. We're going to figure this out. And so there's a national project called ALZNet, the Alzheimer's Network. I serve on the executive committee as a scientific advisory for this. And also we're collecting this data. It's people that were clinically prescribing this medicine, sending in information to a national database so that we can track what's the best practice in clinic for us. We also know that infusions mean coming into the infusion center, once every 2 weeks and getting an IV and sitting there for an hour. Now we're doing our infusions out in Wellington Way, which has great parking. Easy access, you don't have to go to UK proper, everybody's petrified of in general. But we're working right now with our phase 3 subjects. We've switched them over to subcutaneous. And so that data was just presented 2 weeks ago at the International Clinical Trials on Alzheimer's Disease Conference in Boston, and I was there. And subcutaneous, so you could give yourself a shot at home like a diabetic does for their diabetes, and you don't have to go in for infusions. And it turns out that the initial data anyway shows that the sub-Q injections are safer and even more powerful than the intravenous. So that kind of rocked the world. Many national media picked up on this. It's going to take us another year or two to get definitive evidence and to get FDA approval, but that's where we're going to make it easier for folks. So the real question that I want to transition to is, why only 30%? We're getting rid of 100% of the amyloid. Why doesn't it completely stop the disease? And so there's really 2 explanations. One explanation is we're waiting to treat people until they have memory loss and functional loss. They've been building up amyloid in their brain for 20 years. Maybe we need to be finding people when they're still normal, but building up amyloid. And if we get rid of it, then could we completely prevent Alzheimer's disease? That's a real question. The other is, most of our folks, it is rare, only about 30 to 40% of Alzheimer patients have pure Alzheimer's. No one can scratch their head because these medicines slow the disease by 30 to 40%. Is that a coincidence? Maybe they work in people with pure Alzheimer's disease much more powerfully, but don't work as fully if people have TDP-43 late, or vascular hardening of the arteries, or Lewy body pathology, which we know can be present in as many as 50% of patients. And we do know that the majority of patients, right? So if we look here at a percentage of people with dementia that have pure tau in this gold bar, 20%. This is from our autopsy, Dr. Nelson's work. And those with all 4 pathologies, 20% of people, right? Those with more than one, almost half of all Alzheimer's cases have something else besides Alzheimer's. So that's a real issue. So what about earlier treatment? Well, we're doing that right now with what we call the AHEAD study, where we're bringing in people over the age of 60 and testing them with a blood test to see, are they likely to be building up amyloid? And if the answer is yes, then we're getting a PET scan. And if they truly are building up amyloid, then we're putting them on Leqembi, the new medicine that's been FDA approved. Still a research study but we're testing this right now. So enrolling at UK and not only across the nation, this is funded by the National Institutes of Health, but also in Australia, in Canada, Europe starting a program like this, Japan starting this. The US is first, number 1. But people are catching on. As a matter of fact, we were the first. People make fun of the FDA and say, well, you can never get medicines in the United States. We were the first country in the world with an anti-amyloid therapy approved. Japan just approved it. Eisai's from Japan. the company that makes the medicine. They just approved it about 2 weeks ago. We've had it approved since July. The European Union is expected to approve it in the next few upcoming weeks. Anyway, and this is really what demonstrates that this red line is people with Alzheimer's, memory and thinking problems. And you can see after the age of 65, this doubles every 5 years and just skyrockets people with dementia. But if we look at people who have come to autopsy, maybe they passed away from a heart attack, or they got hit crossing the street by a car or a motor vehicle accident, and we look for Alzheimer plaques in their brain, you can see after about the age of 45, the likelihood of plaques increases, and these blue dots are what the PET scan shows. We know that this delay is about 15 to 20 years. So we need to get people early. That's what we're doing with the AHEAD study, and we'll see if we can completely prevent the disease. That's wonderful. Or maybe we need to treat these other diseases as well. So we're not done with our testing and developing of experimental medicines, right? So one could think, what about targeting the tau integrals? What about targeting the alpha-synuclein? What about targeting the TDP-43? And Pete talked about the SMART-HS study. What about hardening of the arteries? What about abnormal protein shapes? What about metabolic dysfunction? What about lifestyle? This is important. So let's talk about that. What are we doing in the field? Well, this is what we're doing. And most of these studies are happening right now, right here. Tau antisense oligonucleotides. This is preventing tau from building up in the brain. This may be very, very powerful for frontotemporal dementia as well as Alzheimer's disease. And these oligonucleotides, now these are complicated medicines. About once every 6 months, you have to come in, and the medicines are given through your spinal fluid in your lower back. But it's only once every 6 months, and they can completely shut down pathologic tau. Completely shut it down. This early data is incredibly impressive, just coming out this year. Remarkable. This is a study, a new vaccine. This is a vaccine that targets aging. And on top of all of our chromosomes,
Yes, I do.
We have these little orange caps called telomeres. And a baby has 15,000 telomeres at the end of every chromosome. But as we become an adolescent, we lose about 5,000. We only have 10,000. Midlife, we only have about 7,000. By the time we're older, we only have 4,000. We've lost. This is part of the aging process. And so the general inkling is that age is the #1 risk factor for Alzheimer's. Can we slow brain aging? And so this is a vaccine that prevents these telomeres from shrinking. And so on memory and thinking testing, this lower line is placebo. Up here is people being treated with these medicines, slowing the aging process and preventing their cognitive decline. Impressive. So aging. This is about metabolism. So this is new agents for diabetes that are out there. You hear them on TV, Ozempic, Rybelsus. They're called GLP-1 agonists. And they're being used right now to treat millions of people worldwide for their diabetes. Now for weight loss as well. And what they noticed was that they looked at the older folks with diabetes treated with these medicines. They looked and say, well, are they developing dementia at the same rate? And so this is people not on those agents, and this is they're developing dementia over time. By the end of 5 years, almost 60% of them developed a dementia. And if they were treated with one of these GLP-1, oh my God, only 20% develop dementia. So this has been the impetus to move forward. And when we look at the brain, this is an Alzheimer patient. Their brain is powered down. This is energy in the brain. And if we put them on these medicines, the brain powers back up again. It's like recharging the batteries. These medicines are also looked at for Parkinson's. They may benefit, improve Parkinson's disease, the way people move. They reduce your stroke risk by about 30%. So right now there's two international studies ongoing, EVOKE and EVOKE Plus, right here at the University of Kentucky as one of the sites, looking at people with Alzheimer's and people with Alzheimer's plus hardening of the arteries with these medicines. Exercise is also great. We know people that don't exercise at all have their risk of dementia set at 1. If you do a low amount of exercise, right, and what's low, less than 30 minutes 3 times per week, you can reduce that by about 1/3. If you exercise more than 30 minutes 3 times per week, you can actually reduce your risk for Alzheimer's by about 60%. That's pretty profound. And we know that that's from brain health mechanisms. So there was just a study that came out, UK was part of it, called the EXERT study, where we looked at exercise and we took people with mild cognitive impairment and gave them a trainer at the Y and a free membership and said, go and exercise 3 days a week. And they might have been, if they were on placebo, we didn't know what to do for placebo. So we said, well, you're going to go to the Y and you're just going to stretch. But we're not going to get your heart revved up. We're not going to make you really exercise. We're just going to stretch and limber up. And the other group, we're going to torture you and make you sweat and get your heart rate up. And they looked at the study and it was a complete bust. No difference between the two groups at the Y. We said, well, God, that can't be right. So we went back and we looked at a group that did nothing from a comparable study called ADNI, the Alzheimer's Disease Neuroimaging Initiative. People going about their daily life. Maybe they were exercising, maybe they weren't stretching regularly, they weren't exercising regularly. And when we looked at the data then, all of a sudden we see a dramatic reduction in the development of memory and thinking loss and progression to Alzheimer's. So that was good news. It tells us, yes, you really should be physically exercising. But the best news of all in this study was stretching is just as good as sweating.
Wow. Isn't
that sweet? For me, I can sit in front of the TV. That's wonderful and just as good. So that's wonderful. So protein folding is another issue, and this is something from cassava. It's simophyllum, and we look at the effects here. Somebody they're getting a little bit of a placebo effect, and that washes away, and they're declining. On simophyllum, they're getting better over time. So this data has been very controversial, very, very controversial, but it is incredibly impressive. So there have been accusations that they're fabricating it. I don't think so. Lewy body studies, 2 of them here. I won't go into them because we got to wrap up, but we're working on Lewy bodies. Vascular disease, we're one of only a handful of sites nationally working with the National Institutes of Neurologic Disease and Stroke on fixing hardening of the arteries. And I won't go into that. And of course, TDP-43, we're the only center in the world trying to fix this with our SMART-HS study. So let's look at this, right? Here we are. We've been able to stop amyloid. Oops, but what if we could stop tau and aging? What if we could stop metabolic dysfunction, lifestyle changes, toxic protein shapes, Lewy body disease, cerebrovascular disease, and late? This is dementia in the future. There I am looking for a job. On the other hand, right, for the little ones, isn't this wonderful? So people talk about this, why would I want to participate in a clinical trial? Well, we have folks here. I'm going to show you one case. This is the decline in folks with Alzheimer's disease. This is somebody who came into my clinical trial 10 years ago, phase 2 for lecanemab. We've been following him over time. Here's where he is now, today. He should be dead.
Yeah.
Instead, he's got an MMSE of 18 and is still left at home alone, traveling with his wife on retirement. Unbelievable. Maybe this is just a fluke. Maybe it's just a fluke. Maybe it's just a slow progressor. But I have to think he jumped on board. He got access to lecanemab, Leqembi, 10 years ago. It was just approved this year. And because he signed up for a clinical trial, he is doing great. So that's why clinical trials are an adjunct to care. I want to do more, get on the standard of care, and then look for what else is out there for you individually. So I'll stop there. I'm sorry I went over.
We have a couple questions.
Significantly.
If you,
Yeah,
okay, the first one you may have touched on already, but if you take a blood test and your results indicate that you may be predisposed, what are some of the most effective lifestyle changes you can begin to ward off onset and delay onset? You
Yeah.
kind of spoke to it a little bit.
So lifestyle changes really are summed up by in several different things. We know this because we've looked at this. The National Academies of Science, engineering, and medicine have looked at this and said, clearly, you got to manage your blood pressure. Blood pressure is a #1 risk for Alzheimer's as well as hardening of the arteries. Manage your health risks, diabetes, cholesterol. Make sure you're visiting a doctor and taking care of those. The second is physical exercise, 30 minutes or more, 3 days per week. And again, just a brisk walk around the neighborhood is good. You don't have to pay for a personal trainer or a high-paid position. And then cognitive exercise study that came out this year, fascinating study, looked at one of the computerized brain games that you pay a subscription for, and they say this will prevent Alzheimer's. Well, they were running their study and they didn't know what the placebo group should do. And they said, well, let's have the placebo group do crossword puzzles because we don't think those will help. Know what the results showed? Crossword puzzles really help. And the computerized brain game did nothing. And it was a complete backfire. Complete backfire on them. I think that's hilarious. Now, I do think that computerized games are good. If you like computerized games, go ahead and do them, but brain health should not cost you. Yes, there's an effort to exercise. And then we want folks eating right, not becoming nutritionally deficient. But those are the things that people need to do.
And the last,
When she gets done,
what is the earliest onset you're seeing in your trials, age?
So I have a patient right now who came in to see me a little over a month ago. She has a true genetic Alzheimer's disease, 33 years old. And she's already in the mild cognitive impairment stage. She's the youngest patient that I have. In our clinical trials, typically, and I'm trying to get her Leqembi right now. It's a little complicated because of insurance for people that aren't on Medicare. It's a little complicated because everybody's like, well, wait a minute, she has genetic Alzheimer's and it's not approved for genetic Alzheimer's. I'm like, she has a brain full of amyloid. She's 33 years old. She's got that 2-year-old, a 4-year-old, and a 5-year-old. I'm like, if anybody needs this amyloid medicine, by golly, let's give it to her. In clinical trials, typically there's a cut of about age 50. Where if we see Alzheimer's earlier than 50, the genetic risk is driving it. Now, there are opportunities for those individuals through what's called the autosomal dominant Alzheimer's network. But we really need to do more work there as well. Likewise, we're very discriminatory. Most of our Alzheimer trials, you're not eligible for if you're over the age of 80.
Wow.
That's a big problem. because dementia is skyrocketing in people over the age of 80. It's this problem of complexity of disease. The older you get, the more likely you are to have multiple things going wrong with you. We all know that, most of us that are aging. Anyway, and that scares people away, and we see less of an effect, and they're more likely to get sick or have an adverse event, and that's going to have to go on the package label, and so there's a lot of political pressures that I don't think are right. I don't like ageism, especially as I get older. And we should have access for everyone, right? Everyone.
My husband, who will not be named, has he's pretty late stage dementia, and he has not qualified for any of the studies because he had a pre-existing chronic kidney disease, which has not changed from stage 3 since he got diagnosed. And we think it is because he took omeprazole for a long time. That aside, because he hasn't qualified, I would like to make sure that whenever he dies, we could have an autopsy of his brain to find out what's in there. I think it would benefit our daughters.
Yeah.
And I don't know how to go about that.
So autopsy donation is important. There are several different mechanisms. For folks that are in our longitudinal research program, Dr. Nelson does autopsies on them. If they're not in our research program, then he will not do an autopsy on them. If folks can look at their healthcare network, so patients at UK can get an autopsy if they're a UK patient. They just need to request it at the time of death. There are some other, and then there's a national program as well, which is run through the NIH, which basically will autopsy anyone who has a potential brain disease as well. So we can get you, so there are multiple ways to approach that, but it's important to plan during life. And what we tend to get a lot of is folks that have not planned in life, and then their loved one passed away unexpectedly, and they're calling in the middle of the night, and nothing's been pre-set up. And by the time we try to get things set up, it becomes impossible.
I understand that, and that's why I've been I've already been turned down by the NIH study. But I'm gonna try that
I'm
again.
shocked you're not good.
You had to have 2 family members that.
Gotcha.
2 people. Well, I'm gonna go back and try again because his mother had cognitive impairment at the end. I'm gonna try that.
So,
But if we have to do it on our own, I'm willing to do that.
So it can be important, because we do know without autopsy, without the biomarkers, now it's also possible, that we could, Medicare has just opened payment for the amyloid PET scanning, which again can tell you very similar things to what an autopsy would tell you in terms of confirming the diagnosis. We do know that without those biomarkers and without an expert, the accuracy of the diagnosis of Alzheimer's is only about 70, maybe 80%. And the 80% figure comes from the leading centers in the nation, so we're not real good without the biomarkers. And sometimes it is important. It's important for family members to know and understand. With that being said, I'm not really, with the progress we're making, I'm not worried about our children.
I've heard someone tell me that.
I'm not worried, with the discoveries that we've made and that we are making. It's only a matter of time before they're going to come in to their doctor when they're 50, and their doctor's going to say, time for your shingles and your Alzheimer vaccine. Roll up your sleeve, right? Because we'll have safer vaccines, better vaccines. And that's, what we're going to do. Yeah, that's at least what we think we're gonna do. We think we're gonna do that fairly soon. It's coming.
I had a question. You spoke about like early testing. Is there some sort of test that you think should be happening in the PCP office?
I think so. The a comprehensive Medicare wellness examination requires, and it used to say that required that you addressed memory. Right, and so for many primary care physicians, I was like, hey, having any trouble with your memory? Of course, the person with a memory problem was like, nope. Fine. They were like, great, check that box. I'm gonna bill you for that one. Yeah, but now they've gotten a little more stringent, said, you need to, and at the time, they also provided a series of tools, said, pick one of these are preferred, pick one of these, but nobody was doing that. They're getting a little more stringent where they actually want you to do something. Or they're not gonna pay you. Now, with that being said, we really have to fix it. We really have to fix the Medicare system, right? Because the Medicare system, most docs have figured this out. If they spend an hour to an hour and a half doing a comprehensive wellness examination, they get, I don't know, 7 RVUs or whatever they get for it. It's a return value unit for people in healthcare. Whereas if they took that hour and saw 6 patients for 10-minute visits apiece, they can make 2 to 3 times as many RVUs. It has disincentivized. Again, this is, I think ageism is at the root of this. It's disincentivized doctors to be comprehensive. What's the fire today, right? All right, we'll put that one out. See you next year, Meanwhile, the forest is still burning, they only put out 1 tree. That's a real problem. That's my commentary on the healthcare system. We need to be a little more rational, and we need to go back and not think about money first. We need to think about people's health first. And then we need to figure out how to pay for it afterwards, And as I always say, I'm sorry if some taxes need to increase. I'm happy if my taxes need to increase for healthcare and or public education. I'm completely on board. Help our children, help our elderly, help sick people. I'm good. Tax the hell out of me. Don't tax me to kill people. I do not want to pay for war. Anyway, that's just where I am in the grand scheme of taxation. Well, thank you all for your attention. I'm so sorry that I went over.
No,
So much.